With this, we'll request Professor Nitin Verma to give his keynote address in this session. Dr. Nitin Verma is President Transco and is guest of honor in our inaugural in this present All India Ophthalmic Society meeting. A very good clinician and a surgeon. Sir, please.
Thank you. Good afternoon, and thank you for inviting me to be part of the AIOC. It's always great for me to come meet friends, but above all, learn a lot. I'm going to talk to you about geographic atrophy. Geographic atrophy is a very sort of common, not often discussed, but fortunately something is coming around the corner. I'd like to acknowledge the input of Robin Geimer, Mary Raphael, and Ursula Schmidt for I've used some of their materials. Currently, there are no treatment approved for GA, either to prevent it, to slow its development, or once it's established, to slow its progression. But there's novel interventions in the pipeline, and I think once the first drug is approved, it will change not only the life of the patient, but also the life of the ophthalmologist. And I think what I'm trying to tell you or trying to share with you today is what's around the corner and how we should be prepared for it. It's not going to be like the treatment of neovascular AMD where you treat everybody. And so we really need to start thinking about geographic atrophy. Geographic atrophy has traditionally been defined based on the appearance of a color fundus photograph. There's nothing more that's needed to define and detect geographic atrophy. But inherited retinal disease can often mimic geographic atrophy, and obviously you need to differentiate between the two. Otherwise, you can treat one or you can help one, but you can't help the other. So the thing to look at is the presence of drusen, because you won't get drusen in IRD, you'll get drusen in macular degeneration. Another commonly should be used, but not commonly used, is fundus autofluorescence, because this gives us the ability to delineate geographic atrophy. It also gives us the ability to detect the growth of the geographic atrophy over time. And it's also a very good way to show a patient like this is what it is, and whatever's black on the fluorescent on the autofluorescence are the areas that are not working, and they're the areas that don't see. But all the trials for geographic atrophy really looking at fundus autofluorescence as as the sign of growth. When you do autofluorescence, there are common patterns of geographic atrophy, but on the autofluorescence, you can see there are either focal changes, there are banded changes, or diffuse trickling changes. It's the diffuse trickling changes which are on the side which tell you that the geographic atrophy is going to progress faster than the other two. So we really need to start thinking about autofluorescence. Now, geographic atrophy is a multifactorial complex pathogenesis of which perhaps 70% is genetic and 30% is to do with lifestyle and physiology. And of course, there's no lecture or no treatment that is complete without looking at the genetics. And we know that the number of genes have got a role to play in the complement system. And there's plenty of evidence for that. In the development of geographic atrophy, there are a number of pathways implicated. And the treatments that we've got for geographic atrophy are designed to address many parts of this pathway. So this is what's in the therapeutic pipeline for geographic atrophy. But I'm going to concentrate on the complement pathway today because that's what's really around the corner. We can detect C3 and C5, these are complement proteins in drusen and also in the sub-RP space in AMD using immunofluorescence. So it makes sense to suppress this pathway and maybe reduce the growth of the geographic atrophy. So one such drug is pegasitacoplan, which is a complement inhibitor that targets the C3 and C3b. whether it comes from the classical pathway, the lectin pathway, or the alternative pathway. If we block C3, we could protect the cell and prevent cell death. The 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 study that's just that has been published, but is going to guide our next step in the treatment of GA, are the Oaks and Derby trials. They're pretty similar. One used microperimetry and one didn't, but really it was the injection of pegcetacoplan either monthly or bi-monthly, or then of course the sham arm, and it really looked at the progression of the growth or the slowing of the growth as the primary endpoint at 12 months, and then also a couple of other parameters at 24 months. So it's a big study with over 1,200 participants worldwide. And I'll just go through very simply the reduction in the rate of growth, as you can see, in the first 12 months was only 16%. In the Oak study, and in the Derby study was even less. So it sort of was, is it really working or not? But when you go on to 24 months, you can see the arms are diverging from each other, indicating also that the every month versus every month was better, but together they had similar results and was much better than sham. This is an example of growth of the lesion. Geographic atrophy, linear growth is about 100 to 150 microns per year. So really you're looking at small amounts of retinal tissue that are being lost. You can convert the measurements into the amount of preservation of retinal tissue, as you can see here. 0.82 square millimeters of retinal tissue in this graph, but as you go on towards 24 months, you can see that the amount of retinal tissue, whether it's subfoveal or non-subfoveal lesions, there is preservation. And in geographic atrophy, most of the preserved tissue or the remaining tissue is non-subfoveal. So it sort of changes the paradigm a bit, because things like BCVA and all don't really matter. What matters is the reduction in growth of the lesion, and whether it's subfoveal or non-subfoveal, the effect is there. You can also calculate the number of cells, the photoreceptor cells that are saved, and that's shown over here. BCVA, as I said, is not a good indicator, simply because there's no good vision to start with. So it's nice to look at lesions at about 250 microns from the foveal center. And that is where this sort of diagram comes in, because the BCVA is correlated with the proportion of the fovea occupied by the geographic atrophy. And you can see here that the BCVA, the less the foveal involvement, the BCVA is better. But if you look at lesions that are 250 microns away, you can see that the baseline BCVA is actually preserved, as you can see here. Microperimetry in the junctional zone, which is 250 micron and beyond, can actually prove this point. And what we've seen is that if you do microperimetry there, you can show that there is a functional preservation in terms of reduction in mean sensitivity and also the number of scotomatous points. So there is retinal tissue preservation and functional improvement. This animation from Vienna, from Ursula, you can see that photoreceptor alteration exceeds and precedes RPE loss. So there's photoreceptor thinning, which is found in the junctional zone, but this photoreceptor loss happens before RPE loss. So using AI and OCTs, you can see in these graphs that they look quite similar to what the Oaks and Derby study graphs showed. So we can see that the loss of photoreceptors and therefore RPE, as that gets more, function also decreases. So it's one tool that one can use to see what's going on. The adverse events were similar in both studies. No events of intraocular inflammation or endophthalmitis. But what was interesting was the development of neovascular AMD in eyes who were getting monthly injections was much higher than the other arms. But these were mainly occult lesions, obviously not subfoveal, because there was nothing in the foveal region, and they were treated with anti-VEGF. So that's one thing to consider. And also to remember that these injections are much higher volume. than the standard anti-VEGF. They're 0.1 mil. And so there was no problem with intraocular pressures. So other trials working on the complement pathway, this one which reduces the C5, with Zimura also has similar results. This is the GATHER trial. So it looks like the pathway inhibiting, complement activation seems to be one way to go. And so new results will again. What about people with bilateral GA the inhibition of complement factor B can be done with a subcutaneous injection because complement factor B comes from the liver. So that might be something that we are all looking for, the holy grail to be treating eye disease without poking the eye. Gene therapy in Australia, we've got 3 trials going on, the Explore, the Horizon, and the Telescope trial. The advantage here, it's a one-shot treatment, but I think we just need to watch this space. And finally, the reduction of cell death is still in the phase 1 situation. So there's a lot happening in the geographic atrophy space. I think from our side, we need to be prepared for it. We need to start thinking of geographic atrophy as a disease that something can be done for in terms of reducing progression. Again, you want to be able to demonstrate progression by using autofluorescence for now. You need to be able to start the dialogue with your patients and saying, listen, something's coming. We're going to map it and see whether your GA is static or it's moving, in which case you can offer them treatment. But above all, we need to be able to confidently diagnose GA, and it's not so difficult, so that when the new drugs come, we are ready to help our patients with them. Thank you.
Thank you, Dr. Nitin. That was an excellent talk. Is there any question for Dr. Nitin? Dr. Nitin, just one question. This is Syfovre has been approved as a monthly injection in cases of geographic atrophy, FDA approved. What kind of patients in your clinical practice do you think a geographic atrophy, what kind of patients would be the first movers to try and use this as a monthly injection to prevent? Are you looking at more of those with preserved foveal function as of now who would be looking at using it more often?
See, geographic atrophy traditionally starts not in the foveal region, but in the perifoveal region. So that you can have many patients who've got geographic atrophy with good visual, with BCVA. So obviously these would be the patients that you would like to pick up early enough to offer them treatment. But the main thing is 2 things. One, to have a confident diagnosis of GA, which I think if you can see the choroidal vessel, there are a few drusen, you sort of say, yeah, that must be it. And the other thing is to demonstrate progression. So early autofluorescence, to detect movement, because all this takes place over months and years.
Right.
I think that's really the key. To be able to identify these patients, have a dialogue, because unlike neovascular AMD, where there could be not only preservation of function, but also improvement, in this game, it's really, at this stage, about slowing deterioration.
Right. Thank you so much.